Hi, everyone. My name is Gabriel Altit. I'm a neonatologist based at the Montreal Children's Hospital, and I'll try to tackle the question today about the use of pulmonary vasodilator therapies in CDH within the spectrum of cardiovascular management. And so I really don't have any disclosures relative to what I'm going to talk, except that I do have strong interest in congenital diaphragmatic hernia, and I am the webmaster of the neocardiolab.com platform that did receive an unrestricted grant from Mallinckrodt Pharmaceutical for educational purposes. So this is one first review that I'm going to talk about. It's a paper that we authored with Dr. Lapointe, Kimfwindler, and Patel. And I think this figure is quite representative of the course of some of our patients with CDH that we see at bedside, in which we would consider pulmonary vasodilator therapy. We know these patients have a component of pulmonary hypoplasia, pulmonary vascular underdevelopment, probably both affecting the arterial component or precapillary component, and potentially even affecting the kind of venous compartment and even potentially lymphatics. So it's not just a question of alveolar hypoplasia, but really there's a malformation of both lungs, including the lungs that's contralateral to defect. And that's thought to be mediated by various elements, both the fact that there is herniation of some of the intra-abdominal organs that could be part of the culprit attack to the lungs, as there's a growth of the lung, but also of the heart, which is also nested within the chest, and the vessels like the aorta, which in some of these more severe patients may be underdeveloped. And we also know that there may be a component of primary injury in terms of mesenchymal defect and even potentially neurocrest cells defects in terms of migration and differentiation, because we know that the lungs can be diffusely affected. And so these patients actually may present in different manner, and they also come in different spectrum of severity, as we know. And some patients may be quite mild in terms of their phenotype, while others may have cardiovascular manifestation that can be, frankly, clinically worrisome, with issues in terms of oxygen delivery and a mismatch between the metabolic demand and the actual tissue perfusion, oxygen delivery, and nutrient delivery, which can lead to ischemia and organ damage. And some of these patients may present with a picture of quote unquote hypoxic respiratory failure, but may have multiple of these components that are happening at the same time. And so we have limited randomized control trial about the best strategies. It's quite difficult to run trials in these patients because they have such a dynamic cardiovascular phenotype. But we're going to try to put in categories some of these phenotypes that may be intertwined. So traditionally, we've been very focused on the fact that these patients seem to have a very high pulmonary vascular resistance. We call this the pulmonary arterial hypertension or precapillary phenotype. But in recent years, we've been uncovering that many of these patients may present also with left ventricular dysfunction, right ventricular dysfunction, even shifting phenotypes between presentation. And of course, all these elements are impacted by the transition, acidosis, some of the interventions we've done, whether prenatal, postnatal, whether or not there's ductal patency and how much this duct is able to decompress either the LV or the RV, what's happening to the preload of these ventricles, which can be interdependent on both the ventilation that you're doing, because high mean airway pressure may impact alveolar pressure and then eventually compress some of these vessels and reduce the left atrial preload. But high pulmonary vascular resistance can also affect the left ventricle as such. And we also know that an RV that is pressure overloaded will eventually pancake your left ventricle. And all of this being nested in hypoxia and low blood pressure or low transcoronary perfusion pressure can also impact how your ventricles are being perfused, especially knowing that as patients will go into RV hypertension, they may get poor compliance of the right ventricle and high right atrial pressure, and that can impede some of the venous flow coming back from the coronary sinus. If you mix that with poor LV output, then obviously your transcoronary perfusion can be quite impacted. So I will refer a bit to the Canadian guidelines on which I am one of the authors. Their reference here at the background from one of our pediatric surgeon who is a really, great thinker and expert in the field of CDH, and is also a pediatric intensivist. And we work closely on our end in Montreal for the management of these patients. But basically, we've put some of the recommendation or key recommendations here, which first of all outlines that echo is a great tool to better understand the physiology of these patients. And of course, you need to be careful about when to intervene, how to intervene, and who's doing these images sequences, and what is the information you're going to get. Because, of course, doing a 2-hour sequence of echo and having a CDH baby who's unstable, become very cold and stressed is not necessarily going to be very useful if you have to rescue your baby from quote unquote an invasive echocardiography. We try to call them these very gentle hemodynamics echo, where we try to get to actually what are the exact information we would want. And of course, cardiology is responsible to rule out any structural heart defect, but many of these patients are nowadays diagnosed prenatally, and a lot of these structural heart defect can already be ruled out prenatally, allowing to use echo during the critical period as more of a tool to inform you on the hemodynamics. And so the three classical elements that we typically talk are these patients, and that's another article by Dr. Bombal and Dr. Patel, where there's really mild pH or no pH, or probably should call it high PVR or mildly elevated PVR, with no cardiac dysfunction, good output, good perfusion, and oxygenation status that is pretty good. Then you have these patients that will present with kind of a more classical, what we call precapillary pH phenotype, where they have like expected high PVR or low pulmonary vascular surface area, so a component potentially of fixed high PVR, and a component of maybe reactive high PVR, without having much issue in terms of the drainage component of your patient. So the post-capillary area seems to be not the predominating factor in these patients. And of course, if they have a strict right to left atrial shunt and PDA, then you start becoming very worried that first of all, your PDA might become restrictive, your RV and diastolic pressure is high, and that will force RA to LV pressure. So these patients will become very blue preductally and will be even more so blue in the postductal territories. I would say that strict right to left at both level is quite rare. And if you see a strict right to left shunt at the atrial level, you obviously always want to rule out other cardiac defects like TAPVR, for example. And then you may have types of primary LV dysfunction, where in these patients, introducing agents to try to relax the pulmonary vasculature may actually worsen your situation, because these babies already have issues with draining the pulmonary vascular compartment, and they're facing high post-capillary pressures, and that may lead to pulmonary edema and even pulmonary hemorrhages. So these are patients that will typically have left to right shunting at the atrial level and more of a right to left shunt at the PDA level. That's kind of the classical picture. And they have concomitant poor LV function or even LV hypoplasia. And these may present also with more of a whitish, wettish X-ray. And if their lung doesn't have too much QP-QS issues, like for example, if the lung doesn't have a pneumothorax or area of atelectasis or poor ventilatory areas or poorly recruited areas, then you expect your pulmonary venous return to be nicely saturated. And so typically these patients will have a preductal sat that is within adequate saturation, unless your PDA is actually contributive to the flow into the ascending aorta retrograde. And at that point, of course, you'll get some desaturation preductally, but you wouldn't necessarily get much differential between your pre and postductal saturations. But you can see that just, combining the X-ray, the physical evolution or clinical exam evolution, your echo evaluations, and looking at the function of your ventricle can already direct how you're going to be dynamically managing these patients. And I wish there was like a one particular answer at saying where I'm going to start pulmonary vasodilator. But for me, my answer is more, I need to go see my baby, examine, evaluate, and try to be as physiologically sound when I addressed my instability. And I will not just treat my echo, but I'll try to put like the whole package, like what's happening to my patient as well. So that's the classical picture of a large duct that is right to left, and you get a completely right to left interatrial septum, interatrial shunt. So in these patients, you would be concerned that you have high PVR relative to SVR. Now, because the duct is wide open, technically your PA pressure will equalize with your aortic pressure because two boxes that are connected with a wide channel will equalize pressure on both sides, like P1 equal P2. And as this PDA becomes restrictive, then the afterload of the RV may become quite significant and your RV may start failing. So that would be definitely a situation where I start becoming worried and a situation where I may actually consider reopening the duct. But in a patient like this, I would definitely consider INO therapy, maximize my ventilation, support my recruitment, diminish my oxygen consumption by, introducing some mild sedation and analgesia, avoiding overt manipulation of these patients. And of course, I would be very careful about maintaining pulmonary vasodilators like INO if my shunt becomes mostly left to right, because I also don't want to start increasing the QPQS to the lungs. So being something very dynamic, it's something that, it's a patient I would monitor and consider weaning the INO as soon as possible when I see shunt reversal. So this is pretty much the representation of this echo, except here I've put like a very tiny duct. So when you do have a tiny duct, you may lose these pre and post ductal saturation because you don't have a huge right to left shunt volume through this duct. And because the duct becomes restrictive, you won't have pressure equalization on both sides, and suddenly your RV can become suprasystemic in pressure as well, and not just suprasystemic in resistance. And at that point, your RV may be failing. And so in these patients, if we do end up having these patients showing up with poor RV function, I would consider also adding some kind of inotropic support. In our center, we'll typically do a bit of epinephrine, 0.02 to 0.05 mics per kilo per minute for these patients. And we would also consider milrinone if the baby is peeing, because it tends to be renally excreted, as well as if the patient has normal blood pressure, because it tends to vasodilate also systemically. So this is an example of patient with a pressure-loaded right ventricle. This was a patient actually we tried to wean a few times off INO in the post-operative phase and actually was bridged to sildenafil. Of course, no RCT on that. That's really empiric. And, eventually we were able to wean out the sildenafil a few weeks later. So that's a clear view from the short axis where you see a pressure-loaded RV, a septum that's bowing, and you see that the PDA here is bidirectional but restrictive, and you can see that you have a large component of right to left velocities. So if you kind of use the Bernoulli equation, it means that you have, after the QRS, 30 millimeters of mercury above the aortic systolic blood pressure inside your pulmonary compartment, showing that you have suprasystemic PA pressure in systole. Now, of course, the PDA is not the best structure to use the Bernoulli equation, but it gives you already a sense that this is a suprasystemic RV. And we also had the TR to tell us that. You can also have situation where, your RV is so poorly contractile that you basically don't have any output. This is very rare. This is a situation where your RV becomes almost akinetic and is not able to generate output. And so your PDA becomes left to right, but it doesn't mean that your PVR, what it tells you is that, your duct might be feeding your pulmonary vasculature, but you may still have some degree of high PVR. It's just at this point, because there's almost no flow coming from the RVOT into the PA. It's the aorta that feeds the PA at that point. So this is a patient in which I would definitely consider PGE to reopen the duct if it's restrictive in order to feed the pulmonary vasculature. And I may consider INO plus or minus an inotrope to support the RV to kind of generate anterograde flow and the RV outflow tract. But you have to be very careful when it's fully left to right. Although once you start kind of increasing your RV output, this shunt may becomes bidirectional. But you have to be careful when a PDA is fully left to right, because you also don't want to create a steal effect from the coronary circulation. Then you have a situation where the duct actually closed and your RV becomes very hypertrophied or failing. And of course, these patients may be very hard to reopen the duct. And in these patients, I may consider some degree of pulmonary vasodilation to support RV output and decrease the RV afterload if there is a sense that there's a significant right to left fraction of blood going from the right to the left, like in this picture, and to decrease the RV afterload and eventually to allow the RV to remodel and be a bit more compliant. And then you have finally these LV dysfunction patient or LV hypoplasia patient, where actually the right to left shunt at the ductal level is sustaining the systemic vasculature. And in these patients, I would actually avoid putting pulmonary vasodilator. And you may be fooled because they may have pre and post ductal SAT differences because blood flow comes back to the LA, goes into the LV is failing. So there's high LV and diastolic pressure, which makes this shunt completely left to right. So these patients may not have pre-ductal desaturation unless you have a component of this PDA right to left shunt that actually feeds retrograde the ascending aorta if there's barely no LV output. And so we see that this is an example of a patient with CDH who has a left to right shunt at the atrial level. You see it's almost under pressure because the LA is probably under pressure in the context of this LV that's barely moving. And so these are patients we would mostly manage by maintaining the duct open and supporting inotropy, so epi and a bit of dobutamine unless the patient is tachycardic, or epi with milrinone, depending on the BPs, because milrinone has a tendency to drop your blood pressure. So that's the example where this patient had some biventricular dysfunction, but LV more than the RV. And by strain, we did strain analysis. You could see that, the ejection fraction was quite depressed at 21%. And there's many variation, and that's why it's often important to re-examine your patient because they are very dynamic. They have no or small PFOs. They may have a duct that becomes restrictive. They can have concomitant underfilling or pulmonary parenchymal disease. So it's important to check these things. A few cohorts from Dr. Patel, Dr. Fraga, Dr. Lee that outlined that the LV may be affected in many of these patients in the first 48 to 72 hours of life. And that you can see that some of these patients may have biventricular dysfunction. And obviously, many studies have tried to decipher whether or not starting pulmonary vasodilators improve the outcome of these patients when trying to classify these patients. But one of the issues with these studies is that they take like one time point to categorize the patient when we know these patients are actually shifting dynamically throughout these different spectrums in time. Hence why I believe that obtaining bedside evaluations may improve how we manage these patients. So another article by Dr. Gowda, Dr. Patel, talking about the precapillary phenotypes and the postcapillary phenotypes and how they may be interdependent and how your management on the respiratory status and may affect also your pulmonary vasculature. These were two papers in reference regarding our own cohort when I was at Stanford, showing that LV function was also associated with the outcomes of these patients. I'll skip that. So in the paper that I mentioned at the beginning, we've put here some of these different phenotypes that I've outlined, knowing that they may shift between the different elements. So I think if you have a situation where clearly it's a precapillary phenotype, then at this point, it makes sense to try to optimize the pulmonary vascular resistances by optimizing the preload, avoiding lung overdistension, considering pulmonary vasodilator, sometimes maintaining the duct, and sometimes supporting the RV function with things like dobutamine or low-dose epi or a combination of low-dose epi plus milrinone. If you have a clear postcapillary pulmonary hypertension phenotypes with severe LV dysfunction, then at this point, these are patients you would want to have some inotropic support and avoid pulmonary vasodilators. And if you have a component of both, then this becomes a bit more tricky. And these are patients where having the duct open may help sometimes if you have a predominant ventricular dysfunction. And one of the ventricles supporting a bit more the circulation of the other. As well as, obviously providing inotropic support. But these are patients where I would be a bit more careful about kind of throwing pulmonary vasodilators without first rescuing my cardiac dysfunction. So these are patients, we monitor the hemodynamics very closely. We avoid excessive fluid intake in these patients. We try to use echo guidance to support targeted treatment. But of course, if they're doing well, we're not going to necessarily jump on them the first 24 hours of life, especially if they had a fetal echo that was normal. We try to avoid excessive manipulation, avoiding too many people in the room. We have the most experienced personnel to care for these newborns, and we try to actually cohort some of these cares. We encourage the presence of the parents. We avoid too many skin breaks by having umbilical arterial line, and we do manage these patients in a multidisciplinary fashion. For the cardiovascular, as I mentioned, INO for us is our primary way to go if they have a phenotype of high pulmonary vascular resistances and RV dysfunction. We do consider milrinone if the BP are adequate and if the urine output is okay. We would consider PG only if the duct becomes restrictive and if you do have cardiovascular instability with significant RV or LV dysfunction. I'm going to tell you, it's actually quite rare that we do have to start PGE in these patients. And when we do, we're very careful because we're very worried about reversing the shunt, especially if INO is on board. So we do monitor them very closely. And then epi tends to be something that we use to support cardiac function. And we do use vasopressin or norepi in situation where you have preserved RV and LV function, but you start having signs that you have low SVR, such as in patients where there may be a bit too much side effects from like fentanyl infusions or things like that, that may be contributive to the phenotype. So again, I think this figure outlines well how these patients can be very dynamic. I've put again this article about the heart of the matter, which is a great article talking about the dependency on these two phenotypes. I'll let you read on it. Shiran Moore and Dr. Shiran Moore, Dr. Keller wrote with me another paper here that is a nice review talking about these different phenotypes and how we would tackle them. So I invite you to go see that. With the different medications and their expected effects. But one key thing is that if the baby's not improving on your therapy, you need to sit back down, see your patient, reevaluate, bring a friend, try to understand what's happening, and then sometimes even go back to square one. And sometimes our assumption of the effect of these medications may not be totally right for this particular baby. This I'll skip. These are the mechanisms of the pulmonary vasodilator. You can find it on some of the reviews by Dr. Satyan. I'll skip this. And then I just want to finish by saying that if you go on the website neocardiolab.com, you'll find a section called congenital diaphragmatic hernia. And I've put a lot of the different articles and presentation actually on this section. So you'll be able to navigate and find some of these resources. So for example, even some cases with great articles. But I do think that these patients deserve to have coordinated, gentle hemodynamics, very thoughtful interventions, avoiding polypharmacy, and making sure that you don't necessarily just treat an echo. We've seen patients who actually on a clinical level had really mild respiratory symptoms, limited oxygen exposure, and then we did the echo and we did find like quite a big RV with sign of, septal flattening or even sometimes septal bowing with PDA becoming restrictive, but overall clinically the patient was well with normal lactates, normal pH. And so these patients, we tend to be a bit more conservative, to be honest. We're not going to jump on them with medications, but we do monitor them closely to make sure that we don't need to intervene quickly if there's any signs that they may be not tolerating the changes in postnatal transition related factors. So I hope this helps. I wish I had the pure answer to you to when to start pulmonary vasodilators, but I think my get-to message is go to the bedside, see your patient, put together all the variables, and try to delineate what's the phenotype, and then decide, does it make sense to start something that will vasodilate the residual pulmonary vascular network, knowing that some of these patients may have a component of fixed PVR, which means that they have a limited pulmonary vascular surface area, and at some point the four alveoli are dilated. and there's not much more to dilate. So then you have to support downstream the cardiac function, and that's when some of these agents that are inotropic support may be of help, knowing that they also have side effects and that we should wean them as soon as possible once they're not needed anymore. Hence why it's so good to have a team-based approach, speak kind of the same language, and being able to set certain targets and thresholds for when to escalate or when to actually wean some of these therapies. I hope this helps. Have a great day, and I'm available for any questions, comments. You can go to my website. You'll find my contact at the bottom of every page.